First, let all introduce myself. My name is Reinold Gans. I'm an internist by training. I have been for 25 years the head of the Department of Medicine in the University Medical Center in Groningen. And I'm currently still the head of the Acute Care Center. And I am the president of the section of Internal Medicine by the UMS and the chair of the European Board of Internal Medicine. I'm going to talk about EPAs, Entrustable Professional Activities in competency-based education. And this is my disclosure. I have nothing to disclose. Before talking about the Entrustable Professional Activities, I think that we need a small amount of introduction to competency-based education. I'm aware that there are people in the audience who are very versed in competency-based education because of the CanMEDS framework, but I still want to do this for those who are not really into this item. The ultimate goal of medical training is that we expect physicians, residents and specialists that they all that graduate, that they can be trusted to provide high quality care. And we have in the Netherlands a Dutch medical act which states that licensed physicians are entitled to perform medical tasks provided they are competent. So I graduated from a medical school in the Netherlands. I can do everything in medicine, neurosurgery, name it, provided that I'm competent. But what is competent and how do we know this? So this is a definition of competency. It was published in 2002 in JAMA. The habitual and judicious use of communication, knowledge, technical skills, clinical reasoning, emotions, values, and reflection in daily practice for the benefit of the individual and the community being served. When you discuss it in this way, you can recognize several domains: a cognitive domain, a technical domain, an integrative domain, context, relationships, we collaborate with people, we collaborate with patients, affective, moral, and also the habits of mind. And I would call this a reflection. And one of the most important things that I think that I can teach residents is how to reflect on practice, and ultimately what I hope is that they can reflect in action. The Lancet had a paper in 2010 in which they called for reforming medical education, which was already taken place in Canada, I would say in 1996 when they came up with the CanMEDS framework. And what we should do is actually in each society identify the desired outcomes, health outcomes, define the level of performance for each competency, develop a framework, and evaluate the program. So competency-based medical education is an outcome-based approach. And it is the outcome-based is on the health needs and the health system of your society, your local society or a national level or regional level. And what is important is that exposure and dwell time are not sufficient proxies for competence. You should not shoot for the floor, but competence, you should aim for excellence. And what is the main difference is that as opposed to a traditional program is health outcome-based, it's learner-driven, it's the student and teacher together working, it's not knowledge acquisition, but it's knowledge application, and it should be authentic. So the education should mimic real tasks of the profession, and we should directly observe people to make sure that they are competent. These are just a couple of frameworks, Canada, United States, the UK, and I will consider the CanMEDS because that was the one I chaired a committee in the Netherlands that introduced the competency framework across all medical specialties. And they recognize 7 roles. You see this in this flower. I will not go into all the roles. And they constitute a framework that describes the qualities of professionals. And it should guide learners, the supervisors, in teaching and assessment. The problem is, it's very difficult teaching competencies. The domains are very broad and diverse, and often teachers, they focus on isolated behaviors. Often feedback does not transcend scholar and communicator. I have several PhD students who have assessed many work-based assessments regarding all kinds of tasks. And most of the time they will make a comment about communication, they will make comment about scholarship or evidence-based medicine, and that's it. So people have difficulties how to translate all those competencies, those 7 competencies that we have adopted, into the world of medical practice. So there were some innovations from the field. One from Canada itself, they came up with the milestones. And in the Netherlands, we came up with the Entrustable Professional Activities. So what are milestones? Milestones are the stages in the development of specific competencies, a continuum for medical school through residency to practitioner. So this is the whole learning road from the start to actually become a master. And what is important, milestone at each stage describe the attainment targets, what you should be able to do at that particular stage. It gives us a learning roadmap. At the same time, how does this help us with actually assessing residents? It's very difficult if you have 7 roles or 7 competencies. How do you rate a resident at the end of a rotation for each domain? So you have to rate them for scholarship, for a health advocate, for communicator, for collaborator, for the professional. How do you do that? People found it very, very difficult. And that was why we came up with the Entrustable Professional Activities. The learning roadmap, it should be grounded in our clinical context of each medical specialty to make it meaningful. And the Entrustable Professional Activities is an assessment that matches the responsibilities in patient care. It's an integration and it is not a separation of competency. And it should be practical, which is very important. So this is the definition that Olle ten Kate from the University of Utrecht in the Netherlands came up with. It translates competency in clinical practice. It should be professional life activities that define the specialty, and it's defined as tasks of responsibilities to be entrusted for unsupervised execution by a trainee. And it should ground the competency in physicians' everyday work. So what are we talking about? Performing an acute take, rounding a ward, performing a consultation for internal medicine in a ward of another medical specialty, and so on, running an outpatient clinic. And it should all be activities that can be observed. And all those activities should be an integration of knowledge, skills, and attitudes across those competency domains. In such a way, competencies are descriptors of physicians, but EPAs are descriptors of work. So this is just the conditions that have been defined, and which is very important. It should be able to recognize at a output of professional labor, and it should be independently executable, and it should be observed, and it should be acquired in a specific time frame. So what if you put them together in one list? If you see on the right side the competency, those are person descriptors. Knowledge, skills, attitudes, values, you have content expertise, you have communication ability, professional attitude, and so on. EPAs are work descriptors, essential units of practice. Discharging a patient, counseling a patient, leading a family meeting, breaking bad news, and so on. So the competency framework is actually very analytic. We analyze a person in this way, in this framework, while the EPAs integrate the competencies. And what you can see is that for several EPAs, you can see that various roles are important for a specific EPA. Not all CanMed's role in this case are applicable to a particular role, but I would say from almost any activity, it's just by with what glasses you look at someone. I could look at the same activity from a scientific aspect. I could look from the same activity from a communicating aspect or collaboration and so on. You have to choose with the EPAs which you really think, which competency are essential for that particular EPA. What is important also is that when you focus on assessment, we focus now on the EPA. Is someone competent to independently execute that particular task? When I'll give feedback, I focus on competencies. I might choose to focus on collaboration, or I might choose to focus on scientific content and so on. This is what we use, and this is used in now many countries, is the EPA template, which has a specific title. You give some specifications and limitations of the EPA, and you define which competencies are most relevant for this particular entrustable professional activity. And then you define the knowledge, the skills, the attitudes, and the experience. And then we also state what kind of assessment should be performed to show the supervisor that someone actually has achieved everything what is necessary to become entrusted for this EPA. It might be that there are pre-EPA prerequisites, which means is, for instance, to be able to go to the, to be able to allow to perform an acute take in my hospital, you have to follow beforehand an advanced life support course. Without an advanced life support course, you are not allowed to go into that particular rotation. So that is a prerequisite for this particular EPA. But then the problem is, when is a trainee competent? And a professional activity is mastered at a certain threshold level that permits trust, that act unsupervised. So competent is actually a stage in a developmental continuum. I always say we learn 60% of medical care in a particular medical specialty within your training program, and over the rest and the remainder, if we ever learn that, we do the rest of our life. This is the growth, just a picture of how you can show in a graph growth of competence over time. So during training, at some point in time, we declare someone competent, ready for unsupervised practice. After that, people may become proficient or even a master. And at the same time, CME and CPD, continuing medical education, continuing professional development, is actually needed to maintain that competence. This is just an example for a competency curves for one trainee for various EPAs. And what you can see is that some EPAs you can be entrusted early during training, and some will take more time, depending upon the rotations and so on. And at some point in time, we say you have gathered all the EPAs that are necessary, for instance, for the training of internal medicine. And in the Netherlands, we have defined 16 EPAs. And if you have mastered them all, and we entrust you with working independently, you can go on with deliberate professional activity. But interestingly, what people do not realize is we also unlearn things, because we do not see particular groups of patients. And what you see in this graph also, that at some point in time, if we would assess one for that particular EPA, the person would lose actually that EPA. But that's something we hardly ever do. We always say at some point in time, you pass your exam, and then you are fit to practice for the rest of your life, and God help us all. What are the levels of supervision? In general, we recognize 5 supervision levels. The observant, we have a supervisor. You see a patient, and the supervisor is with you. It's a direct supervision. Then at some point in time, we say it's an indirect supervision. I'm next to you, or I'm in another room, and then you see the patient, and then after that, we see the patient together. And at some point in time, we can do independently with only a post hoc evaluation. And that's the entrustment level that we need for independent practice. And naturally, and we also train residents for that, you might actually be a supervisor for particular activities. How do you make the entrustment decision? This is portfolio-based. It's a progress interview. The resident, in this case, gives a self-evaluation based upon their own impression, but also based upon whatever they have put into their portfolio that actually supports the entrustment decision making. And we have a discussion as a supervisor with the resident, and we say, decide upon what level this particular resident is for that particular EPA. And we do this really on a formative basis. It's a coaching session. It is not a summative assessment. The entrustment decision is a summative assessment. So what is the toolbox for the components of testing? This can be anything. Case-based discussion, observed clinical activities, a whole list. How someone acts in a morning report or on-call service or ward rounds. You also have knowledge-based exams and other forms of assessment, professional presentation, multi-source feedback, OSCEs, and clinical examination. And all these come into the portfolio. And we define for each specific EPA what kind of evidence should be in there. The trust concept is a difficult one. Trusting someone and say you are fit to practice this on your own it makes yourself vulnerable, because we take a calculated risk that adverse events that may occur are acceptable. You say, we can never aim for not acceptable. Why is this? If we see, for instance, which is always a nice explanation in my view, is if you see a patient with a suspicion of pulmonary embolism, we do a D-dimer, and then we do a CTA of the pulmonary, we do a pulmonary angiogram, and then if there is no pulmonary embolism evident, we say you do not have pulmonary embolism. No, but actually that's the incorrect answer. The answer is there's a 1.5% chance that you will return to the ER within 2 months with a pulmonary embolism. Lucky for you, you won't die from it, because that was the result of the particular studies. So you can never, so this is what I would say a calculated risk. Every day we use and make calculated risks. The other thing is that greyos will be certified to perform activities that maybe I never have observed them doing. And learners may have even never encountered those particular activities. So entrustment decisions is about adaptive competence. We think that if we bring you in an unknown situation, you have the competencies to be able to do the right things and ask for help if needed. And this is what we call rich entrustment decisions. It's just more than just knowledge and skills. Something about a gut feeling is also in this. So how do we do entrustment decision making? We give a lot of formative feedback. We do a lot of coaching projects. They collect a lot of evidence in their portfolio, and then we discuss the particular trainee in our group, the whole training group. And sometimes it may be the gut feeling. We still do not think, despite all the evidence there, we still do not think that we can entrust this person to work on its own. Then we have difficulties explaining that. But we use this as the group, because supervisors have often difficulties assessing competencies and also the work-based assessment, and it's all subjective. And every now and then we have experience in which we say, I'm not sure whether or not this person can do this. But we try to do our best, but we make it a team decision. What might the future look like? Above the line, the transverse line is you see what happens. Before medical license, you do not have autonomy, you have no privileges and responsibility. Then during training, you get limited autonomy, privileges and responsibilities. And then suddenly, at some point in time, as if, sudden, at one point, you are allowed to do everything. You get full autonomy, full privileges, and so on, which is kind of strange, because we do learn we develop during medical school, we develop during training, but we only declare someone fit for practice at one particular point in time. And what is better, in my view, is what you see also on the lower slide, is during medical school, you also learn particular tasks that you can be certified to perform. During COVID time, my department refused medical students to take blood from patients in the ICU. They refused that they did some particular activities. So what did we do? We trained them We certify them, and after certification, as a medical student, they were allowed to perform very circumscribed, small tasks that we entrusted them to perform well. The same holds true during training in regular training. During training, you have to be certified during all your years that you are entrusted to do this particular activities, and for that particular activity, you still need supervision. And then it's just much more gradual, then it's not a final, then everyone knows at the end of training that they are fit for practice. It's a formality, if it's correct, it's a formality to say, now you're fine to do. And the same true after graduation. What I said, we unlearn things. And at some point in time, you may move to another city and maybe see groups of patients that you have not seen maybe for 10 years. So what is better than get recertified for that particular activity by an EPA, in which you are confident that you are able to independently treat those patients at a sufficient level, and society is also happy because you have shown that you can do this. I will leave it to that. Thank you.